So thank you very much for inviting me to your symposium. I must say that I am a cancer epidemiologist, but I was appointed as the director of the National Center for Epidemiology in my country, that is part of the Institute of Carlos III, that after listening to the previous presentation, I realized that we have a lot in common, because we were also founded in the 19th century because of infectious diseases, and we have been doing the transition to be the National Institute for Health Investigation and providing also advising our Ministry of Health. So
almost there.
Yeah. So because I was as I told you, I was appointed as the director of the National Center for Epidemiology. I took charge of our study in COVID, that was the Spanish nationwide epidemiological study that was mentioned before. Okay. So these are the three first epidemic waves. I don't know if this is working. Yes. The three first epidemic wave in Spain. Looking just the numbers of our national surveillance system of cases of COVID-19, you can say that the first one was a mild wave. However, if you look at the excess of mortality, we have a system in my center that has monitorized mortality on a daily basis, and based on the 10 previous years, I cannot see this is not working, but it's easy to see in the picture that we had a huge excess of mortality that was occurring in the first wave. So why a seroprevalence study? Well, the thing that we knew about the new infection was from our surveillance system, and there you see that there were more women than men, and also that it seemed to affect mainly to old people. But okay, so sorry. But from this study published in 2016, you realize that serological surveys are very important when you have incomplete detection. We were running short of PCR tests. We had to increase our, as you did here, we had to increase our capacity, our ability to produce PCR tests. And also, we didn't know at that time, but we suspected that there were a substantial proportion of asymptomatic cases, because we had cases without contact, non-contact with another case. So we were mandated by our Ministry of Health to design a study, a seroepidemiological study, to know the spread of the new disease across the country, and to evaluate risk factors that promote the infection, and if possible, to evaluate the evolution of the epidemic. So following the WHO advice, we decided that households were going to be, sorry, this doesn't work, households were our sampling unit, and we stratified. We wanted to have information in each region. Currently, Spain is divided into 17 autonomous communities, but they are very heterogeneous in size. But in the 19th century, we had a previous division in provinces that are still in force. So we have, it's there are more homogeneous in terms of space. So we decided to use provinces. We wanted to have information for each of our 50 provinces and 2 autonomous cities that are in Africa, as you know, Ceuta and Melilla. So we stratified by geographical region, and the second level of stratification being a respiratory disease, we knew that population density was a very important factor. So we took municipal size as a surrogate of population density, and we stratified by that. At that, our first guess was that probably overall in the national number could be around 5% of people infected. We were quite right, but this was by chance. The thing is that being the first epidemic wave, you cannot expect a great spread of the disease. And so we decided that we had to recruit 90,000 people in order to have 60,000 of them participating. We thought that 2 out of 3 would like to participate. Well, we performed 3 rounds of the study. You see that in the 14th of March, there was the declaration of the state of alarm in our country, in my country, and this was followed by a severe lockdown. Nobody could step essential workers. We couldn't move. This is Madrid downtown during that time, and this is very, very difficult to see because this is a square that is always very crowded, even during the night. So you can see how was our country when the study was performed. So that situation imposed a lot of challenges, logistic challenges, because we only had less than a month to perform the study, to put it into play, and we had to coordinate the 17 autonomous communities, all primary health services. We have to develop the protocols. We have to train the professionals who were going to be our hands in the study. We were collecting the forces of the National Microbiology Center, that is part of my institute, but also another 28 laboratories collaborating with us. We have to provide the whole regions with the material that we are going to use, and also the legal support. We built up in the Ministry of Health an information system to collect all the information from our participants, and we built a training platform in my institute, so the health professionals that were going to perform the study could have the protocols and see the videos of how to obtain the information we were requesting. Possible participants were contacted by phone. We randomly selected them from the census roll in Spain, and those who agreed gave information about their household, and they have an appointment to the primary health system, or some health personnel went to their house depending on the situation. They signed an informed consent. All members of the household were recruited if they wanted to, and we decided to collect 2 kinds of samples. We use a rapid test that you can see there to facilitate participation, and we also took serum samples. At the beginning, we thought that we couldn't, because we didn't have a good assay to analyze all samples, but before just starting, architect test appeared, and this test allowed to test a lot of samples very quickly with a robot. So we decided to apply to all the samples. So these are the questionnaires. The epidemiological questionnaire was for each of the members of the household, and there was an overall questionnaire for the household. And these are the 2 tests that we use. The National Center for Microbiology was testing a lot of rapid tests to see if there was one that we could use. And suddenly, this oral gene appeared, that had reasonably good sensitivity, more than 80%, but it has very good specificity. In our small study, 100%. You know that we wanted to have a lot of specificity because the prevalence that we were anticipating was not quite high. So we were more concerned about false positives than about false negatives. And this is the other test that we use that requires many function. And this is a meta-analysis that we performed with all the studies available. And you see that it has a very good sensitivity, 90% overall, and a very, very good specificity. To my knowledge, this is the most specific test on the market. Well, this is the paper that we produced, and because we used 2 tests addressing 2 different proteins of the virus, we decided to combine the information from this test, either to have a very sensitive estimation of prevalence, allowing a positive or being positive if they tested positive in one or the other test, or very specific information on seroprevalence, deciding that requiring that both tests would be had to be positive. Well, this is a comparison of our demographic structure and our participants, and we have a very high rate of participation, more than 70% of those who could be contacted. We were under lockdown, so many people have moved to a second residence during the lockdown to stay there in the beach, and they could not be contacted by phone in their registered residence. These are the main results of our study. Either using the point of care, the rapid test of the the test with more precision, you see more or less the same distribution. The highest prevalence was in Madrid and the surroundings. So we think that the infection came to Madrid and we spread it around the country, because most people in Madrid, including myself, we are not from Madrid and we spend a lot of time in our places of origin. If we compare this geographical pattern with the pattern that we have from our national surveillance system, they didn't agree so much, because you have some areas they are very dark in color, and this is because the PCR testing was not homogeneously available across the country. So if you took the information from the surveillance system, you had somewhat a distorted picture of what was going on with the infection. We were the first study providing information on seroprevalence from babies, children lower than 1 year, to nanogenaries. So Spain is one of the countries with the highest life expectancy in the world, and our population is quite old. So we have people up to 102 years old participating in the study. And also we saw that when we had the seroprevalence data, there were not much differences between men and women. So what we saw in the surveillance system is due to the essential workers. Most essential workers are health workers, and in Spain, 3 out of 4 health workers are women. This is why we got this impression of the virus being attacking more women than men. We, with our national estimate of seroprevalence, we knew that at least 2.5 million people were infected during the first epidemic wave, that around 30% of infections were asymptomatic. This was the first population-based estimation of the percentage of asymptomatic infections. We knew that healthcare professionals were heavily impacted. They duplicated the seroprevalence data compared to the general population. And we saw also that the most important risk factor that we found is to be living in the same house with a known case of COVID-19. And this pointed out the difficulty in Spain to isolate people in their own homes. It's very difficult. You tell them you have to be in a separate room, but we are very social. Sometimes we leave a lot of people together. This didn't work as it should. The mortality was a very polemic issue in my country, because the media were saying that the government was lying because we have more deaths that they declare, and so on and so forth. So we decided to estimate the mortality due to the virus in our country. Since we have this excess of mortality that I showed you, the expected number, daily number of deaths is the line in blue that you see there. And we estimated with mathematical models taking into account the mortality we observed in the 10 previous years, nationalizing the secular trends, because otherwise you cannot have this. So you have to bear in mind that in mortality figures, we have 2 different effects of the pandemic. One is the virus infecting people with other chronic diseases or not, and contributing or directly killing them. And this is the direct effect. But also our health system was completely overwhelmed in some regions in Spain. That meant that people with chronic diseases were too afraid to go to the hospital, or could not be attended because the system was, as I told you, completely overwhelmed. So this is an indirect effect. And I think this is the discussion that was provoking the differences in number in the media. So And in the literature, in the scientific literature, they were mixing the case fatality risk, and that is the risk of dying among COVID-19 cases. But you know that at that time, in most countries, we have incomplete as the timing of cases, so the denominator wasn't completely known. But there is another figure that probably is more interesting, that is the infection fatality risk, and is to put in the denominator the number of infected people. And we have a good estimator of that from our sero-epidemiological study. So we decided to estimate the number of infected from our sero survey and to take in the numerator either the number of dead people with COVID-19 that came from our national surveillance system, or at the most, taking all the mortality that was in excess in our daily, in the MOMOS in the mortality surveillance, daily surveillance system. We took both estimates. The first one could underestimate the infection fatality risk, and the other one for sure would overestimate, because when we did this computation, we were assuming that all the deaths were occurring among infected people. We had to remove deaths that were occurring in nursing homes, because by design, nursing homes were not included in the surveillance system, because our unit of sampling were households. And after doing that, we found that in Spain, the lethality was more or less 1%. It's difficult to compare countries with different demographic structures, because as you see here, there, the right, the lethality increases very sharply with age. That is normal. It's something that we have already seen, and is always greater in men than women. But our estimate was in agreement with a meta-analysis that was performed actualized several times by Meyerovitz, Pratt, and et al. When they were joining together studies that they considered that have low bias. The last thing that we have performed is to characterize asymptomatic infections. We see that they are more frequent in men, that they are more frequent among the youngest and the oldest people, and also that they are more frequent in people who haven't had contact with cases. And when we consider the percentage of asymptomatic infections regarding the overall seroprevalence in Spanish region, we see that it depends on the circulation of the virus. In those areas with a higher circulation of viral circulation, then the percentage of seroprevalence is lower than in areas where there is lower circulation. We have characterized also the syndromic presentation of COVID-19. At that time, we thought that dyspnea, lack of oxygen, cough, and fever were the triad that served to diagnose. But in cases occurring in the general practice, this triad is not regularly seen. And these are the presentations that we observed among infected people. And taking into account symptoms, we have performed a symptomatic risk score to guess among symptomatic cases, people who have some symptoms compatible with COVID-19, to help primary health workers to guess if these people have COVID-19 or not. Our symptomatic score that is based in anosmia or ageusia, that scores, I suppose that you know what is. This is the sudden loss of smell or taste. This scores 5 in our system. Fever scores 2, and absence of sore throat scores 1. That means if you have sore throat, it's an indication that probably this is not COVID-19. And severe tiredness score 1. And if your score is 3 or greater, the probability of having COVID-19 is high. The sensitivity of our score is greater than 70%, and the specificity also. So this is, sorry, this was animated. These are the main strengths and limitations, I think, of our study. I think that it was very nice that being able to provide geographical information, because as you saw in the picture, the differences in seroprevalence was huge, were more than 5 times higher in places with great high seroprevalence compared to those with low seroprevalence. But well, the study is not perfect. This is the coordinator team in the all autonomous communities and in the Ministry of Health. You cannot read anything, but this is just to show you that there were a lot of people involved and more than 5,000 professionals. In fact, now when I go to different parts of Spain and give a talk about this or other topics, at the end, always there is someone that comes to me and say, "Oh, I was part of the seroprevalence data," and that's very nice. I was very, very happy. And if you want to know something else, we have a web page that you have here the address, and everything is explained there. Most explanation of the protocols are in Spanish. Sorry, we didn't have time to translate, but the publications are in English. And thank you very much for giving me the opportunity to talk to you about this.